oro-antral communication. Right, so this is the lecture content. So we're going to talk about the anatomical consideration, the etiopathogenesis, clinical features, and also the clinical management. Right. Okay, if you still remember from your last lecture, when we talk about maxillary sinus, I remember that I mentioned the maxillary sinus has multiple walls. One of the wall is inferior wall, which is also known as the floor of the sinus. Okay, the floor of the sinus expand inferiorly as you grow older, and the expansion goes beyond the inferior border of the nasal cavity once the upper permanent teeth are fully erupted. All right, so now you can see how the relationship of the floor of the sinus and the tip of the root of the upper posterior teeth plays an important role in the formation of oro-antral communication. Okay, so what is oro-antral communication? It's basically an unnatural communication between the oral cavity and the maxillary sinus, meaning any communication between the two cavity, the oral cavity and the maxillary sinus is known as oro-antral communication. Here you can see the clinical pictures of an oro-antral communication, and here is the radiographic features of the oro-antral communication. You can see a breakdown of the bony continuity at the alveolar ridge, which goes right into the maxillary sinus. Okay, right. So then what is oro-antral fistula? Okay, so initially we have oro-antral communication, and if the oro-antral communication is not being repaired, there will be epithelialization of the margin and along the track of the communication. So this condition is later known as oro-antral fistula. So oro-antral fistula is basically an abnormal epithelialized, okay, that's the important word, epithelialized communication between the maxillary sinus and the oral cavity through the perforation in the sinus wall. So perforation can be through the inferior wall or the floor of the sinus, which is the most common one, or it can also occur at the anterolateral wall of the maxillary sinus. So that is a different version or different category of oro-antral communication. All right, so here you have one oro-antral communication right at the alveolar ridge of the upper jaw, and this one at the anterolateral aspect of the wall of the sinus. So this is basically at the vestibular region. All right. So oro-antral fistula develops when the oro-antral communication fails to close spontaneously, or if it doesn't go any surgical repair. So it remains patent and it gets epithelialized. So there will be migration of oral epithelium into the defect. So that once the epithelial layer has formed, it will never fuse. It will never seal off the opening. Right. So this epithelialization usually occurs when the perforation persists for at least 48 to 72 hours. So within few days, the fistula will get organized, and with the epithelialization of the fistula tract, osteitis of the surrounding bony margin, meaning inflammation of the surrounding bony margin will happen, will take place, and then there will be present of foreign bodies in the sinus, because the tract is the opening of the tract is patent, so food can go in, fluid can go in, so any foreign bodies can go into the sinus, and also it can lead to the development of maxillary sinusitis. So when this happens, spontaneous healing is usually hampered, which may result in a chronic fistula formation. So fistula tract present for more than 14 days should be considered as a chronic fistula. So when you have a perforation, initially it is known as oro-antral communication. All right. After 48 to 72 hours, you will have epithelialization of the opening. Right. So when you have the epithelialization of the opening and the tract of the perforation, then it is known as oro-antral fistula. Right. So don't get confused with initial stage of oro-antral communication with oro-antral fistula. So oro-antral fistula basically is a chronic event. Right. So there are a few different, few types of oro-antral communication. Yeah, I use the word oro-antral communication. So there are three types. One is alveolo-sinusal oro-antral communication. This is the most common one. Okay, this is the most common one. Alveolo-sinusal. So this is alveolo-sinusal oro-antral communication. Basically, the communication occurs on the alveolar ridge. Okay, so the main cause basically traumatic extraction. So you can see the opening here. A traumatic extraction of the upper molar tooth has resulted with the perforation of the floor of the sinus and also the lining of the sinus. All right. The second type is what we call palato-sinusal. This is where you have opening at the palatal aspect of the palate, of the maxilla, palatal aspect of the maxilla. So basically, the etiology it can be due to malignancy or trauma. Malignancy, for example, you have squamous cell carcinoma forming at the palatal area. So you went in for surgery. If you don't repair the opening, it will form a palato-sinusal oro-antral communication. Okay. Trauma. If you have a palatal split, meaning the palate split into two, and if the area has not been repaired, it will end up forming a palato-sinusal oro-antral communication. Right. And the third type is what we call vestibulo-sinusal oro-antral communication. So this is the one. So it's basically formed at the anterolateral wall of the sinus. The alveolo-sinusal and the palato-sinusal forms at the floor of the sinus or the inferior wall of the sinus, whereas the vestibulo-sinusal form at the anterolateral wall of the sinus. So this basically because of complication of surgical procedure. The most common surgical procedure that we do in this particular region is what we call Cartwell-Luck procedure. Maybe you, some of you have heard about Cartwell-Luck, but for those who have never heard about Cartwell-Luck, this is what we call Cartwell-Luck procedure. It's a surgical procedure for us to approach the maxillary sinus. So what you do a vestibular incision. You cut at the vestibules and then you raise the flap. And then if you still remember from the last lecture, that you can make a window, bony window at the thinnest part of the anterolateral wall of the sinus, which is at the canine fossa. Remember I mentioned this during the last lecture. So here you have raised the flap, you have exposed the bone, then you have created a window at the thinnest part of the canine fossa. So then you can raise the floor of the sinus. Once you raise the floor of the sinus, you are in the antrum already. All right? Okay. So this is another view of surgical approach. Okay, you can see this is the bone. There is the thinnest part of the canine fossa. So you can make a hole there. All right. So one of the complications, sometime after surgery, you have a fistula forming at this particular region, at the vestibule region. So that is what we call vestibulo-sinusal oro-antral communication. So it's basically a fistula. So remember there are three types: alveolo-sinusal, palato-sinusal, and vestibulo-sinusal oro-antral communication. Okay. So let's look at the etiology. The most common etiological factor for the formation of oro-antral communication or oro-antral fistula is dental extraction, traumatic dental extraction. Extraction of the upper molar and the premolar contribute about 48% of all the cases. So this is the major contributing factor. Reason because of the close anatomical proximity or projection of the root within the maxillary sinus. As you grow older, the sinus will be growing towards the occlusal surface of the tooth. So it will go around the tip of the roots. That is why it will grow inferiorly. So the expansion will go inferiorly. Right? So when there is a very close relationship, when you're trying to remove the tooth, And if when you have a complication, the root fracture, and then you try to retrieve the root using an elevator, sometimes if you don't do it properly, you may accidentally push the root or your instrument through the floor of the sinus, and you may break the sinus lining. Sometimes you just break the floor of the sinus, but the sinus lining is intact. So most of the time, the root is not in the antrum, but underneath the sinus, underneath the sinus lining. So that should be very easy to find. That is why if you have any fracture roots, always send for X-ray first, at least a periapical view. So then you can tell whether the root has gone into the antrum or lying underneath the sinus, because your treatment plan will be different. Okay, right. Okay, the second cause or the second etiological factor for oro-antral communication is what we call tuberosity fracture. This is very common in a lone standing maxillary molar. And when you have a lone standing molar, usually the tuberosity will be very thin, very weak. So when you try to remove the tooth, it will fracture. So if you remove the tooth with the tuberosity, two things will happen. One, there will be massive bleeding. Why? Because the posterior superior alveolar artery will be entering at that particular region. Second, there will be big cavity there. So you will have an oro-antral communication. So my clinical advice, if you happen to be in that situation, when you try to remove the tooth, you feel that you have break the tuberosity, stop your procedure. Okay. If there are other teeth around the area, you can use an arch bar to tie or secure that fragment. Okay. Then you leave it for at least 4 to 8 weeks for the new bone formation. So after 2 months, you can go in and do a surgical removal of the tooth, right? Okay, so that will prevent fracture of the tuberosity. It will prevent massive bleeding, and it will prevent any formation of oro-antral communication, right? Okay, because I have encountered a number of cases referred from private where patient come with massive bleeding from the tuberosity area. All right. Okay, the third etiological factor is dentoalveolar or periapical infection coming from the upper molar tooth. Okay. The fourth etiological factor is implant dislodgement. Sometimes when you do surgical placement of implant, if you don't do a proper radiological assessment, sometimes when you insert the implant, depending on the thickness at the floor of the sinus, you may dislodge the implant into the sinus. That's why you have to do a proper investigation. You want to see how much bone is there at the apical area. So when you drill, when you do the preparation, you know that you won't be perforating through the floor of the sinus. Okay. So the next cause of etiological factor is maxillofacial trauma. Just now you saw the palato-sinusal oro-antral communication due to palatal split. When you have a fracture of the maxilla, you heard about Lafort 1, Lafort 2, Lafort 3 fracture. Sometimes you may have a palatal split, meaning the palate split at the midline. So when the palate split at the midline, the palatal mucosa will get tear. So there will be, you can see a perforation through the palatal area. So this need to be repaired, because if you don't repair the area, food and fluid will go into the perforation, and then it will cause so much of problem. Okay, then the presence of cyst or tumor in the maxillary sinus also can cause oro-antral communication. Basically due to the surgical procedure, because when you do the surgery, you remove the tumor or the cyst either from the vestibular area or from the alveolar ridge area. Sometimes you may end up having a perforation or a fistula formation. So when that happens, you will have fluids or foreign bodies going into the antrum, right? So the presence of cyst or tumor in the sinus can also become an etiological factor for the formation of oro-antral communication. Okay, osteomyelitis, right? Inflammation of the bone, inflammation of the bone marrow, and also osteoradionecrosis can contribute to the formation of oro-antral communication, because that part of the bone which get involved, the bone become rotten, the bone will damage, and then when you do a clearance of the affected bony area, you will end up perforating the floor of the sinus. So when that happens, you have to cover the defect. So how to cover the defect, that will be discussed later. Right? Okay. Then sometimes because of flap necrosis, remember the Capbell-Luck procedure? Sometimes after you have done the procedure, you close the flap. Sometimes you do have flap necrosis. It can be due to patient factors. It can be to the patient systemic illnesses. It can be due to the poor oral hygiene or poor compliance to the post-op instruction. So flap necrosis can lead to oro-antral communication. Okay, this one, complication of Capbell-Luck we have mentioned just now. Malignancy, yes, remember the case of squamous cell carcinoma, for example, on the palatal area, it will cause a big defect on the palate when you remove the tumor. Okay, right, okay. When we look at the relationship of the tooth to the floor of the sinus, you look at the sinus, you look at the root. So once the root, once the permanent tooth has completely erupted, you will see the sinus will start going all around the apex of the root. So the sinus will expand inferiorly, and this is what we call sinus pneumatization. I did mention this in the first lecture. All right. So when you look at these diagrammatic figures, you can see, like, the relationship of the sinus to the root has different stages. You may have stage 1, which is very close by, and then stage 3, stage 4, where the sinus has really go around, go around the tip of the root. So, and then you may have stage 5, where the tip of the apex just touching the floor of the sinus. So depend on which condition, it may predispose the condition to the formation of oro-antral communication. All right. So the maxillary second molar, this one, if you look at all the molars, the maxillary second molar contribute to the highest incidence of oro-antral communication, which is 45% of all the time. Then follows by the third molar and the first molar. The first premolar contribute about 5 to 3% of all oro-antral communication. Okay. Right. Okay. Condition like, you may have hypercementosis or fibro-osseous lesion around the root of the tooth. This may also lead to the formation of oro-antral communication. Of course, when you remove the tooth, it will be a big defect there. So if the lining or the floor of the sinus is not involved, it's okay. Because with the formation of the blood clot, the epithelialization of the mucosa, this will cover up. But if there is a perforation of the sinus floor, then you will need to cover the area with a flap. Okay, this is what we call just now osteomyelitis or osteoradionecrosis of the alveolar ridge. Okay, you see how the bone is severely affected. So when you remove the bone, you will end up having a huge defect in this particular area, which may involve the maxillary antrum. So that need to be covered. Okay, lone standing maxillary tooth. You see, this is lone standing maxillary tooth, and you see this is a lining of the sinus. You see how thin is the tuberosity. So that is why a lone standing molar tooth can contribute to oro-antral communication. So remember, if you happen to extract the tooth and you feel mobility of the tuberosity, stop your procedure, try to put arch bar from here to here, leave it for about 2 months. for the bone to form, and then you come back after 2 months, you do a surgical removal of the tooth. All right, no more normal extraction, but surgical removal. Okay, all right. Okay, see here you can see from the CT scan how the lining can be very close to the root, and you don't even see, or maybe you can see a very thin layer of bone, or at some places you don't see bone at all. So that can contribute to the formation of oro-antral communication when you encounter a traumatic tooth extraction. All right, so when you look at implant, you see, when you need to do a proper radiographic examination before you can decide the length of the implant that you want to use. Here you can see how implant can get dislodged into the antrum. Why? Because here the bone thickness is very minimum. So you see here, bone thickness is very minimum. So what happened when the surgeon tried to put the implant? It goes right into the antrum. Because during the preparation, maybe the dentist did not realize that he or she has perforated the floor of the sinus. So when you put the implant, it goes straight into the antrum. All right. So this, if you leave it there, if you don't remove it at all, then you will have pathological changes in the antrum. Here you can see what we call polyp formation. All right. This is what we call polyp formation, or you may also have what we call mucosal thickening, because that is how the body responds when you have a foreign body. You may have mucosal thickening in the antrum. All right. So this is another situation where you have the sinus in the antrum. Okay, remember I did mention just now, when you have a fractured root and then you think the root has gone into the antrum, okay, don't simply jump into the conclusion. Always take an x-ray. Why? Because of this. This is the sinus lining. Okay, there is the floor of the sinus. Sometimes the root may only be sitting here. As long the sinus lining is still intact, it won't go into the antrum. It will be between the sinus lining and the floor. But if the sinus lining has been perforated, it will definitely goes into the antrum. Okay, so that is my clinical advice. When you have fractured a root, instead of straight away thinking of it's going into the antrum, take an X-ray first. A periapical view will be very useful. Okay, trauma. Remember just now, the palato-sinusal oro-antral communication. Okay, here you have a patient with fractured left 1 with palatal split. So you can see the mucosa has torn. Then you can see the palate has split. So there is a communication. So when you do the surgery, when you treat the patient, you need to close, you need to repair this, you need to put a plate, reduce the fracture, put a plate, and bring the two end of the mucosa together. All right. So okay, this is a very bad what we call panfacial fracture. Panfacial meaning you have a fracture of the midface and the mandible. That is what we call panfacial. So here you have Lafort 1 and Lafort 2 combination fracture. And actually Lafort 1, Lafort 2, and Lafort 3. This patient has 3 Lafort fracture. And here at the Lafort 1 level, you have a potential oro-antral communication. Okay? Right. Okay. So you may have what we call tumor or cyst in the antrum. So here we are removing the cyst via the Cartwell-Lark technique. We have raised the vestibular incision, create a vestibular incision, raise the flap, and then you created a buccal window at the thinnest part of the canine fossa region. All right, then you remove the whole thing. Okay, once you have removed, you can see the defect there. Then you close up. Okay, but sometimes you may have flap dehiscence. So when you have flap dehiscence, you will have a fistula at this particular region, and that is what we call vestibulo-sinusal oro-antral communication. Okay, here you will have a tumor in the left maxillary region. Here a cyst at the right maxillary region. Okay, right. Here this is where we remove a squamous cell carcinoma of the palate. Right. So I think I did mention about Weber-Ferguson flap design, where you cut at the inferior orbital margin and then lateral to the nose, and then you split the upper lip. All right, then you can raise the flap, then you can see the anterior wall of the maxilla. Here we have cut the maxilla. Okay, so, and here we have removed the tumor. So you can see a big defect there, and you cannot leave it. You cannot leave it there. You cannot leave it alone. You have to restore the area. How to restore? You can either do a flap or you can use a prosthesis. Okay. If you don't do anything, you leave it open, hoping that he will get epithelialized. Yes, it will get epithelialized, but there will be a cavity. It will be a big defect there where food will get trapped. Right. So this is another contributing factor to oro-antral communication. All right, so those are the definitive etiological factor. We do have what we call predisposing factor. So here, as I mentioned, proximity to the sinus floors, hypercementosis, all this has been mentioned just now. Okay, all right. Did I go backward? Hang on. Okay. All right. So how do we diagnose oro-antral communication? Basically, based on the patient complaint. Okay, patient come to you saying that, oh, I have a tooth extracted last week, and then the doctor has encountered difficulty in removing the tooth. So when I go back, when I drink water, I feel like fluid coming out from my nose. That is the most common complication from oro-antral communication. So fluid regurgitation, then you may have altered nasal resonance. Okay. Sometimes when patients try to drink through a straw, they cannot. They cannot suck through a straw. All right. There will be unilateral nasal discharge. Then patient feel bad taste in the mouth and a whistling sound when they speak, and also they will pain at the malar region. This is usually what the patient will be complaining to you. All right. So how do we go about with the diagnostic approach? Of course, clinical history, very important. Get all the correct clinical history because patient will tell you all this. So all this will lead you to the provisional diagnosis of oro-antral communication. All right, then you do your diagnostic approach. What are the diagnostic approach? Clinical examination and radiographic examination. Clinical examination, of course, you have to inspect the patient, right? Okay, you have to start from extraoral, then intraoral. Okay, remember when we last lecture, I showed you how to inspect the maxilla, and you see the overlying skin, the color of the overlying skin. You palpate the area, see for any tenderness. Okay, all right. Then you go inside the mouth. Okay, you inspect the opening. Okay, you notice there is an opening. You inspect the opening. Look at the opening using the mouth mirror, and you need a very good lighting. See whether the opening has epithelialized or not. See whether there is an actual perforation of the floor of the sinus. Okay, but one important thing, do not use dental probe to probe the defect. You shouldn't do that, because when you do that, if the sinus lining is still intact, but the floor has been perforated, when you use the probe, you will break the sinus lining. Okay, so do not use the dental probe. Okay. If patient say there is nosebleed immediately after the extraction, after the extraction, patient go home, blood coming from the nose, that is confirmed that the tooth has certainly lies in the sinus. Why? Because the sinus lining has been perforated. And remember, the sinus lining is very thin, and you have all these pseudo-stratified columnar epithelial layer with the blood vessel there. So once perforated, of course, it will bleed. Right? So then you have blood pooling in the sinus, and then it either come up from the oro-antral communication, or it will come up from the inferior meatus, and then it will come up from the medial meatus and goes into the nose. All right. Then you can do what we call nose blowing test. You get the patient to pinch the nostril and get the patient to blow. So when the patient do the nose blowing test, you will see bubbling at the oro-antral communication. That is positive oro-antral communication. All right. Okay. Again, probing shouldn't be done. Okay. Right. Okay. Radiographic examination. Okay. You can take a plain X-ray and OPG, or you can take a periapical view. Okay. Or you can send for Waters view. Or Waters view, also known as occipitomental view. This is very useful in order to rule out any formation of sinusitis, any pathological changes in the sinus. Because chronic oro-antral fistula you may have mucosal thickening, you may have chronic chronic maxillary sinusitis, you may have polyp formation as well, right? But you can start with periapical X-ray if you don't have OPG. Okay, all right. Scan is also useful, but usually we will send for plain X-ray first. For periapical X-ray, you can use you can use what we call gata pecah. Gata pecah you can insert into the opening, and then you can send for X-ray. From the X-ray, you can see how far the perforation has gone. Okay, right. So this is the diagnostic test. You can use the nose pitching technique, also known as Valsalva technique. All right. So you pitch, try to blow through the nose, and then you see, because of the different pressure, you will see bubble coming up. Bubbling of this particular area. All right. So here you can see radiographically, you can see the oro-antral communication. Or if you use a gata pecah, you can insert and then you can see it clearly. Right? Here we are using gata pecah. Okay, we are not probing into the sinus, but we are using the gata pecah just to see how far the track is. Right? Remember, gata pecah is very soft. Soft gata pecah won't perforate the sinus. Okay, sinus lining. Right? So you insert the gata pecah. Okay, you see the opening here. So you insert the gata pecah. Then radiographically, it will show clearly the sinus tract. Okay. Right. So what are the early symptoms of oro-antral communication? One of, like I mentioned just now, you have fluid regurgitation from the nose. You may have epistaxis, bleeding from the nose, escape of air from the mouth into the nose. So when this happens, you will have alteration in the vocal resonance. So there will be change in the voice. And because of the early inflammation, you may have pain in the surrounding area. Right. So the symptom for a chronic oro-antral fistula, this is chronic oro-antral fistula, you may have pain, you may have purulent discharge, pus discharge coming from the area, you may have post-nasal discharge, you may have possible sequelae of general systemic toxemic condition. For example, you may have fever, you have malaise, and then you may have herniation of the antral polyp. Okay, this is what we call antral polyp. So it's herniated through the oro-antral fistula. Okay, right. So what are the signs of established oro-antral fistula? So you will have escape air or fluid through the nostril, development of polyp, and discharge coming from the orifice. Right. Okay. What happens if you don't do any treatment to the oro-antral communication? One, there will be chronic oro-antral fistula formation. Second, there will be candidal infection. You may have maxillary sinusitis, basically from bacterial origin. You may have inflammation of the bone marrow, which is known as osteomyelitis. You may have rhinosinusitis, and you may have pathological changes in the sinus, which include mucosal thickening. You have polyp formation. You may have sinusitis formation. All right. Okay. So that is the sequelae or complication. All right. So what needs to be done? So basically, we need to do a surgical closure. Okay. But not all cases need to be closed surgically. Right. So in the fresh case, where the opening, for example, less than 2 millimeter, and you know that patient has no history of maxillary sinusitis, you just need to make sure you have good blood clot formation. Right. So what you need to do after you have extraction, do the extraction, there is a small perforation. Okay. You can insert a Surgicel inside. This is one of the hemostatic agents, Surgicel or cellulose oxidase. Insert into the socket and then get the patient to bite gauze at least for 1 hour. So that will stabilize the blood clot. So once you have the blood clot, it will lead to the formation of new bone in the socket, and then of course the mucosa will epithelize and cover the defect. All right, but for a larger defect, you really need to do a surgical closure, because otherwise, if you don't do that, it will form it will come pathological changes such as acute sinusitis. All right. Okay. Closure very important to prevent food or saliva accumulation. Okay. All right. So these are all the problem related to oro-antral communication. You may have pain, you may have poor drainage of the sinus, polyp formation, oro-antral polyp formation. Yeah? Okay. So now let's look at the treatment. Okay. Treatment can be divided into two. Treatment for the acute cases, like what I mentioned just now, where you have an immediate opening, or treatment for delayed cases. This is for chronic fistula, right? Okay. So before you go for your choice of treatment, you need to understand the criteria for selection of surgical approaches. So what are the criteria that you need to know? One, location of the defect. Okay, location of the defect very important. Example, you have alveolo-sinusal oro-antral communication and palato-sinusal oro-antral communication. Okay, so if you want to approach surgically, for this one, you cannot use buccal advancement flap or buccal pad of fat. You may need to use a palatal rotational flap. For this one, you can use buccal advancement flap, you can use buccal pad of fat, or you can use a palatal rotational flap. So location of the defect very important, because that will decide what type of flap you're going to use. The size of the defect also very important, because smaller size, maybe you can use a smaller flap, or maybe you can just undermine the surrounding area and advance it. All right. The height of the alveolar ridge. Sometimes, if the height of the alveolar ridge is disturbing your flap advancement, you may need to reduce the height. Otherwise, the flap will be under tension. Okay. The vestibular depth is also a very important consideration, because that will determine how shallow your vestibule will be after you have advanced the flap. For example, you are doing buccal advancement flap. So when you advance the flap, your sulcus will be very shallow. So when you want to construct a denture in the future, you may need to do some vestibuloplasty before you proceed with your denture construction. All right. Okay, then the status of the sinus. Okay, if patient have sinusitis, you have to treat the sinusitis first. You cannot simply close the defect without treating the pathological changes in the sinus. All right. Okay, and general health of this patient, very important. Diabetic patient, you have to control the diabetes first. Smoker, you have to get patient to stop smoking at least 2 to 4 weeks after you have done the procedure. Otherwise, the whole thing will failure. Smoking, the nicotine will reduce blood supply to the surrounding area. Okay, so this is basically one of the technique to close the oro-antral communication. All right, this is what we call buccal closure of oro-antral communication using buccal advancement flap. You have a defect here, so you can utilize this part of the buccal mucosa. Okay, you can raise a you can raise a flap here and then cut the periosteum. You must cut the periosteum. If you don't cut the periosteum, the flap will get retracted. So the whole thing will be exposed again, right? So once you have cut the periosteum, the flap is very free, there is no tension, so you can pull the flap towards the palatal area and you can suture. So this is how we close the defect. Right. So two principles that you must remember when you are operating for oro-antral fistula. One, the sinus must be free from any infection. Second, the closure must be tension-free. Remember, it must be tension-free, and the flap, the base of the flap must be broad. Very important. Why the base has to be broad? Because for a good blood supply to the area. Okay. Right. So before you do the closure, you must de-epithelize, meaning the defect, you have to remove the epithelial layer around the defect and along the sinus tract as much as possible. Okay. So because if you do not remove that, the flap will never fuse, because flap cannot fuse on the surface where you have established epithelial layer. So you need to de-epithelize the epithelial layer around the defect area, around the defect, before you can raise and advance and suture the flap. Okay. So the success rate for immediate closure, when you have an acute case, when you do the immediate closure, success rate can go up to 95%. But for chronic oro-antral fistula, success rate sometimes can go up to 67%. Right? Okay, so principal management, there are 5 principal management that you must remember. One, any sinus infection, you have to clear that one first. Okay, you must clear all the sinus infection. All right. Second, the preparation for the surgical closure. This is where, what I mentioned just now, you need to de-epithelize the epithelial layer around the defect and along the fistula tract as much as possible. Okay, and then you must remember that you have to evaluate the size, the location of the flap. Location very important, because that will decide which type of flap you want to use. And then right, because the accurate diagnosis too is very important for you. That's why properly assess the size, the location, and then only you can decide which type of surgical approach you want to use. Okay, the third surgical principle, the surgical closure, okay, you need to be tension-free. You must not have any tension on the flap. That is why you must cut the periosteum. Once you raise the flap, you see the inner part of the flap, you will see the submucosal tissue, then you will see the whitish structure, which is the periosteum. Cut the periosteum along the white broad base of the flap. Okay, then only you can advance the flap. Okay, and then any obstruction, for example, the alveolar ridge is very sharp, or the alveolar ridge is very high, so you need to reduce the height. You need to smoothen the alveolar ridge before you can advance the flap. Okay, all right. Sometimes you can also use biomaterial. For example, you can use cellulose oxidized to pack into the area, because cellulose oxidized will will stabilize the blood clot formation. You can also use platelet-rich fibrin. You can also use membrane or bone graft. Bone graft is indicated in a very large defect. Okay, put bone graft and then you can cover with soft tissue on top of the flap. Right. So remember, the first principle is remove the infection. Second, prepare the surgical preparation. Third, the flap has to be very tension-free. Okay. Fourth, very important, post-op care. The patient must follow the post-operative instruction. Okay. So very important to avoid pressure changes. Pressure changes, because patient must avoid action that increase pressure in the oral cavity or the sinus, such as blowing their nose, using straw, or sneezing with a closed mouth. Because when that happens, the flap will fail. The flap will open up. So when the flap open up, the whole thing will fail. Okay, so you have to monitor for complication. So regular follow-up is very essential. Monitor the healing, and you must make sure that you must try to avoid any potential complication like formation of sinusitis. Okay, So, and the last principle is consideration for prompt management. So the early closure is the ideal treatment. So when you have a perforation, immediately try to close it. Okay, do not delay, because if you leave it for 48 to 72 hours, of course, there will be epithelialization of the opening, then fistula will form, and there is high potential for formation of sinusitis. Right. Okay. So when we manage oro-antral fistula, the objective is, one, to protect the sinus from oral microflora, to prevent escape of fluid and other content across the communication, to eliminate existing antral pathology, and of course to establish drainage through the inferior meatus. In cases where you have a chronic sinusitis secondary to the formation of oro-antral fistula, the sinus drainage, the sinus fluid cannot drain out from the sinus, from the maxillary sinus. Remember, the opening of the maxillary sinus is that the medial meatus, which is at the level of the floor of the orbital cavity. So, because the opening is very high up, that is the reason why maxillary sinus is the most common paranasal sinus to get infected. So it is very high up. So when you have fluid accumulation, usually fluid will be very difficult to be drained out. So what we can do, you can do an opening at the inferior meatus. You can go through the nose, create an opening at the inferior meatus, then it will allow drainage of the fluid which is accumulated in the maxillary sinus. So remember the goal of the treatment: protect the sinus, prevent the escape of fluid or other content into the through the communication, to eliminate any existing antral pathology, and of course to establish drainage. Because oro-antral fistula will, one of the potential complication is the formation of sinusitis. Okay. So let's look at the immediate treatment of oro-antral communication. Okay, you have a healthy sinus and oro-antral fistula, oro-antral communication less than 4 millimeter. This one usually you can allow for spontaneous healing. You don't need flap most of the time. So what you need to do, make sure there is blood clot formation. To stabilize the blood clot, you can insert any hemostatic agent, for example, cellulose oxidase, Sigicel, pack it inside, and then the blood clot will get stabilized. And then you can use a suture, a figure of 8 suture over the socket to hold the blood clot, right? To hold the blood clot, and then get the patient to bite with gauze at least for 1 hour. Okay, need to prescribe antibiotics and also nasal decongestion to prevent potential infection and to enhance the sinus ventilation. Okay, always remember you need to inform patient about sinus precaution. What is sinus precaution? Okay, sinus precaution is where you avoid any situation which create negative pressure changes between oral cavity and nasal cavity. Right, meaning you don't blow your nose. If you want to sneeze, you have to control your sneezing. You don't drink using straw. You don't suck using the straw. You don't play any blowing musical instrument. For example, what do you call trumpet? You don't use. You don't play that. You don't blow balloon. You don't blow air in the balloon because that can create pressure changes. So this is what we call sinus precaution. All right. And you can do for immediate immediate treatment of oro-antral communication is you can undermine the surrounding tissue. You have the opening here, small opening, less than 4 millimeter. You have a good blood clot formation. Instead of just putting a figure of 8 suture to hold the blood clot, you can also create some incision around the socket and then undermine the area, and then you can close it primarily. Right? It's basically what we call local advancement of the surrounding tissue. All right. So this is what we mean by sinus precaution. Avoid blowing nose. Do not forcibly spit for a week. No smoking. Definitely no smoking. Don't sneeze with the mouth open. Do not use straw. Avoid swimming. Strenuous exercise for a week. Don't play any musical instrument which need for where you need to blow. For example, trumpet. And do not rinse your mouth vigorously for a week. Do not do vigorous mouth rinsing, at least for a week. All right. What about for oro-antral communication of more than 4 millimeter? All right. So immediate treatment for anything for more than 4 millimeter is flap. Is to use flap, right? So before that, you can reduce the buccal and the palatal wall of the socket. You can use your finger, digitally press the area, it will break the buccal and palatal flap, right? And then you can approximate the two edges of the mucosa, either using what you call undermining of the surrounding area and primarily close it, or you can use flap. But I prefer for anything for more than 4 millimeter perforation, you use flap. All right, flap, you can use buccal flap, you can use buccal advancement flap, you can use buccal pad of fat, you can use palatal rotational flap, or you can use tongue flap. All right. So then post-op, you need to give antibiotic and nasal decongestion, and always practice sinus precaution. All right. Okay. What about treatment for delayed cases? This is for chronic oro-antral fistula. Okay. So first thing first, remember the principle. Palatal rotational flap or what do you call buccal pad of fat. Okay, your choice depend on the principle that I have mentioned just now. Yeah, location of the defect, size of the defect. Those things need to be considered, and then reconstruction of the defect. Okay, and then use proper suture to close the defect. Okay. All right. Choices of flap, you can have local flap or distant flap. You can use buccal advancement, palatal rotational flap, buccal pad of fat. Okay, you can use tongue flap, which is a distant flap, vaccinator or temporalis flap. Okay, right. Local flap advantage, you are basically using tissue, the tissue lying adjacent to the defect, and usually it matches the mucosa to the surrounding area. So advantage has low mobility and very high success rate, but the disadvantage sometimes restricted for closure for of relatively moderate size fistula. All right, so sometimes you may need to go in a few times, right? But try to do once, single attempt, because if you go again and again, there will be a lot of scar tissue formation, and then the flap will no longer become tension free, and the blood supply will also be compromised. All right. You have seen this photo just now. This is where we use a buccal advancement flap. So you have alveolo-sinusal oro-antral communication. So you can do incision around the neck of the tooth, okay, and then two relieving incision. And then you raise the flap. Okay, this is where you do your incision. Then you raise the flap. Okay. Then at the inner part of the flap, at the submucosal area towards the vestibule, you can cut the periosteum. Cut the periosteum, make sure you don't cut the muscle, just the periosteum. Okay, once you have cut the periosteum, the flap will be very free. Okay, then you can advance the flap. Okay, so remember, before you do anything, you need to de-epithelialize the epithelium around the defect and the fistula. All right. Here, this is where you cut the periosteum. This is the vestibule. This is the inner part of the flap. This is where you cut the periosteum. Once you have cut the periosteum, you can advance it freely. Then you can close it primarily. Okay, and very important, here we have reduced the height of the alveolar bone. Yeah. Okay, so basically, if you look from the side, this is the bone. Okay, sometimes the bone is very sharp, you need to smoothen it. If the alveolar bone is very high up, you have to reduce the height. Okay. Yeah. Again here, right? Basically the same thing. Okay. You can also use palatal rotational flap. This is based on greater palatine artery. All right. So this is the defect. Okay. All right. Then you raise a tongue-like flap. Okay. And with the greater palatine artery is within the flap. So blood supply basically comes from the greater palatine artery. So you rotate the flap. This area you can leave it raw because it will become re-epithelialized later, or you can use periodontal dressing. You can pack with periodontal dressing, and then it will allow re-epithelialization of the area. Okay, all right. Okay, this is how you raise the flap. You have to be very careful. You don't want to sever the greater palatine artery. Once everything has been elevated, make sure it's tension-free, then you can rotate and secure the area. All right, so this is how clinically you can raise the flap. Okay, you can see here the inner part of the palatal rotational flap. Here you can see the greater palatine artery. Okay, then you rotate the flap. Okay, this is how it has been rotated. This area you leave it raw, or you can use periodontal dressing, and this is the result. You can see how the area has healed up. Okay, and you have epithelialization of the defected palatal area. Okay. All right. You can also use distant flap, for example, tongue flap. But tongue flap for me is the last resort because if you use tongue flap, the base of the tongue is still attached. The base of the flap is still attached to the tongue, at least for 2 weeks. After 2 weeks, you have to cut the base of the flap to free the flap from the tongue. So during that two weeks of period of healing, the tongue cannot move freely because if the patient moves the tongue around, the flap will fail. Remember, because the base of the flap is still attached to the dorsal surface of the tongue. Okay, here you can see the defect. This is where you use the tongue flap. Okay, right. Okay, this is a tongue flap. Okay, remember, you see here, there is the base of the flap or the pedicle of the flap. Okay, right. Here is the pedicle of the flap. So once you raise it, you secure to the area. This pedicle will need to be cut off after 2 weeks because initially you need that for blood supply. Once everything has healed, you cut the pedicle, and then the remaining of the tissue you remove. Right, and then this area you can suture as usual. All right, but problem with tongue flap, one is mobility of the tongue for that 2 weeks of period of healing. Then you may also have hematoma because tongue is very vascular. You have what you call very muscular. So when you have muscles, you have a lot of blood supply. So it can cause hematoma formation, right? And then sometimes you may have temporary loss of tongue because you have cut that part, but this is not a major issue. And of course, there will be you will be narrowing the tongue. The size of the tongue will be reduced a bit because of the use of the flap. All right, buccal pad of fat. This is you get the fat from the buccal cheek area. The blood supply basically comes from the branches of the buccal artery. So you make a cut at the buccal cheek area. Okay, you pull the buccal pad of fat. Make sure it's not detached from the pedicle. Right. Then you will see epithelialization of the fatty tissue. So the buccal pad of fat will get epithelialized and it will form a normal epithelial tissue. Okay. Right. Bone grafting, as I mentioned before, indicated for a very huge defect. Okay. This is where you can use your own bone autograft or you can use artificial bone. Right. Okay. Sometimes you can use prosthesis to cover the defect. But how long? So patient will be comfortable wearing prosthesis for ages. So usually prosthesis is only for a temporary measure. This prosthesis basically will cover the defect. All right. Okay. The last slide. Okay. So post-op instruction, very important. Okay. This is what we call the all these things need to be stressed to the patient You need to inform the patient again and again. They have to follow the instruction. Otherwise, your flap will fail, right? Cover antibiotic to prevent any infection. You also give nasal decongestion to improve the sinus ventilation. And then sometimes you do give non-steroidal anti-inflammatory drug to control the pain, and you give mouthwash, but make sure patient do not do any vigorous mouth rinsing for the first 1 week. All right. So that is the conclusion of my lecture for today. And then these are the two references that I use, Nelima and also Kili and K. All right. So yeah, that's the end of my presentation. Okay. Okay. Right. Okay. Right. So next week there will be lecture on Shamini. It's osteomyelitis, isn't it? I think it's on osteomyelitis, if I'm not mistaken.
Check Dr. Hordana.
Never mind. I think it's on osteomyelitis. Okay. So I have uploaded the slide last night. Did you check on it? Ada kan? Okay, you can go through the slide, and then if you have any question, you can always message me. Right? You can always message me, and I will try to answer as much as possible. Right? Okay. So, on how many of you attended this lecture today? So 16. Because I think Dr. Abim is very particular about attendance, isn't it? So make sure you remind your friend to come for the lecture lah. Yeah. All right. So have a nice day. Study hard, and then I'll see you again next week, same time on the same day. All right. So thank you very much. Have a nice weekend. Okay. Bye.
Thank you, Dr.
Okay. Bye.